Schizophrenia, a case study. Patient description. Name, Muhammad Arif. Age, 25 years. Gender, male. Presentation. The patient's mother and brother brought him to the emergency department. Complaint. He speaks strangely, does not communicate properly with anyone, and is suspicious of us. Brief history of presentation. Over the past 6 months, the patient has gradually become socially withdrawn, stopped contacting friends, avoids family, and has disturbances in sleep and appetite. According to his family, he says things like, "The TV is talking to me," or "Others are stealing my thoughts." Sometimes he hears voices and talks to himself. Recently, he tried to harm himself with a sharp object because he believed it was necessary to protect himself from future danger. Mental status examination. Appearance. Unkempt. Wearing inappropriate clothing. Mood and affect. Anxious and suspicious. Speech. Speaking at a normal rate, but his speech is disorganized. Thought. Delusions of persecution. Thought derailment. Hallucinations. Auditory hallucinations. Insight. Absent. Judgment. Poor. Necessary laboratory tests. To rule out other possible organic causes, the following investigations are indicated. CBC, to assess for infection or anemia. LFT, RFT liver and kidney function tests. TFT, to rule out thyroid disorder before using antipsychotics. Serum B12 and folate levels. For neurological symptoms, urine toxicology screen to assess for substance abuse, and MRI or CT scan if needed. A scan, MRI or CT, is done to rule out tumors or neurological conditions if necessary. Treatment and management. Start with oral risperidone at a dose of 4 mg per day, increasing the dose based on the patient's response. Alternatives include olanzapine or aripiprazole. If there is poor compliance or the patient is not taking medication regularly, then long-acting injectable antipsychotics can be considered. Other considerations include psychotherapy, such as CBT for psychosis and CBT for hallucinations, along with teaching coping skills for new challenges. Psychoeducation should be provided to both the patient and their family. Social skills training and reintegration into the social environment are important, as is social rehabilitation. Case management, supported employment, and day treatment programs should be considered. Attention must be given to risk and safety in every case. Pay attention to warning signs such as suicidal thoughts or attempts, suspiciousness, or violent behavior. If there are command hallucinations instructing harm, or if there is apathy, safety management becomes crucial. Loved ones should ensure that dangerous objects are not kept in the patient's room. Involve family members as needed, such as by having 15 or 12 people involved, and provide the health helpline number. Also, establish a follow-up plan to prevent relapse. After 1 week, conduct a clinic review to check for side effects such as death, increased weight, diabetes, and extrapyramidal symptoms. Ensure these are monitored. Record the case in the casebook. This assignment for the family includes regular counseling, as this is a long-term, complex mental illness. The journey of managing this does not depend solely on medication. It is essential to consider the patient's psychological, social, and biological aspects together. In this, the role of safety measures and empathetic support is crucial for the patient's recovery.